Now we'll go to the examination of the reflexes. Before going to examination of the reflexes, in the motor system, the power examination, the hand muscles, I want to make one correction. The adductor pollicis is supplied by ulnar nerve. I think by slip of tongue I told median nerve to my students. Adductor pollicis is supplied by ulnar nerve. Okay? Okay. Right now, let us go to the examination of reflexes. First, we'll discuss superficial reflexes, then deep tendon reflexes. Okay? In superficial reflexes, we will also discuss the pathological reflexes. After deep tendon reflexes, we will discuss some primitive reflexes. Okay. Superficial reflexes, already we are discussing cranial nerve examination, the corneal reflex and pharyngeal reflex, the palatal reflex, gag reflex, we have discussed. Next, in the abdominal reflex, you will examine. Okay. Abdominal reflex, how do you examine? Okay. Abdominal reflex, the epigastric region is supplied by T8, umbilicus T10 and here T12, okay, the inguinal region, T8, T10, T12. Then you will give the stroke from lateral to medial and look for the contraction of the abdominal muscles, okay. Contracted that side, contracted here, okay, see it contracted, see contracted, T8, T10, T12. Which are the condition? Abdominal reflex will be absent. Abdominal reflex will be absent in UMN lesions, upper motor neuron corticospinal tract lesions. Okay, it is the earliest to last in multiple sclerosis and it is the last to last in motor neuron disease, even though corticospinal tract is affected. It is also absent in pregnancy, lax abdomen, obesity, or if any nerve herpes zoster is affected. In those conditions, abdominal reflex will be absent. Abdominal reflex will be absent. Okay, right. Next is the cremasteric reflex. Cremasteric reflex, you will just stroke the thigh, okay, from lateral to medial down and you look for the elevation of the testis, the elevation of the testis. You should not just look the contraction of the skin, you have to look for the elevation of the testis, okay. The root value for cremasteric reflex is L1, okay. Ilioinguinal nerve is the afferent, genital branch of genitofemoral nerve is the efferent. In abdominal reflex, one more point which I want to tell is a beaver sign. Beaver sign has a localizing value. Suppose if there is a T10 spinal cord is affected, if you ask the patient to lift the head like that, then the umbilicus will move upwards. Umbilicus will move upwards. That is beaver sign. Next is bulbocavernosus reflex. You will stimulate the glans penis, then you will do a PR examination. At that time, there will be anal sphincter contraction. That is bulbocavernosus reflex. The counterpart in female is clitoroanal reflex, stimulates the clitoris, then there will be anal contraction. The root value is S2, S3, S4 for bulbocavernosus reflex. One more is, while pinching the glans penis, at the base of the glans, you can look for the bulbocavernosus contraction, okay, at the just in front of the scrotum. That is bulbocavernosus reflex and clitoanal reflex. Next, superficial reflex and a pathological reflex in the lower limb is Babinski's sign. Very important sign, the Babinski sign. Now, I will demonstrate how to do a Babinski sign. It should not be a sharp object, it should be a key. Ideally, the key is better to elicit the Babinski sign, okay. So, the foot will be like this, hold it here, fix at the ankle joint. Yeah, the Babinski reflex is elicited by fixing the ankle joint, then come from the lateral aspect of the sole, then come till here and then till the base of the, see you can see the flexor response. Again I will do on this, come from the lateral aspect of the sole, come till here the ball of the great. You can see the flexor response. Now one more way to do Babinski sign is classical Babinski, flexion at the knee joint, okay, dorsiflexion here. And then you can do from the lateral aspect of the sole, then bring till the ball of the thumb. Again, from the lateral aspect of the sole, then bring till the ball of the big toe, ball of the big toe. So, bring from lateral aspect of the toe till the ball of the big toe. Okay, this is how we will see the Babinski. The Babinski, what you look in the Babinski, the root value of Babinski is L5S1, L5S1, okay. Babinski, the normal response of a Babinski is flexion of the great toe and flexion of the other fingers. When do you say Babinski is extensor? Babinski is extensor when there is an extension at the first metatarsophalangeal joint along with fanning of the other toes. That is a classic Babinski. The extension of the metacarpophalangeal joint is a very important movement, okay, not the fanning of the toes. The Babinski sign is extensor in corticospinal tract. It is the hardest sign in CNS. Just to give a few little interesting story about Babinski, it was invented by actually a nurse in a neurosurgical ward. There was a neurosurgical ward where all the head injury patients were there. Whenever the wind comes, okay, whenever the bedsheet used to fall on the leg, that great toe used to like this. The sister noticed and she told the doctor, neurosurgeon, the great toe is going like this. So that is an interesting story about Babinski's sign. What is minimal Babinski? If there is no leg, if there is only stump because of some wound, if you stimulate the stump of the wound, at that time you can look for a contraction of the tensor fasciae lata. That is minimal Babinski. So Babinski has the other components. There will be a dorsiflexion at the ankle joint, flexion at the knee joint and flexion at the hip joint. Triple flexion it is called as. What is minimal Babinski? Minimal Babinski is there may be a brief extension followed by flexion, okay, or there may be a extension of the great toe without the fanning of the other toes, or there may not be any movement at all of the great toe, or there may be just a flexion at the knee joint, hip joint, okay, without any movement of the great toe. This is a minimal, this is a equivocal Babinski. Equivocal Babinski. Minimal Babinski is if you stimulate the stump, there will be a contraction of the tensor fasciae lata, that is minimal Babinski. Equivocal Babinski is these are the things where there is a brief flexion, okay, followed by extension, or there will not be any movement of the great toe, neither flexion nor extension, or there may be extension of the great toe without fanning of the other toes, okay, or there may be no movement in the toes with just flexion at the hip joint and knee joint, okay, that is equivocal Babinski. There is cross extensor response. For example, if there is a one side there is a Babinski, if you stimulate that side, the other side will become extensor. This is because of the increased reflexogenic area, crossed extensor response. Okay. There is one more in a corticospinal tract affection. There is a Rossilimo's sign. The Rossilimo's sign is elicited by it is a flexor corticospinal tract response. You just give a stroke here. Okay. If there is a flexion, here it is not there because it is normal. A flexor response you will get, okay, that is Rossilimo's sign. The pathological reflexes in the upper limbs are, okay, the two reflexes, Hoffman's sign and Wartenberg's sign, okay. The Hoffman's sign is elicited by just doing like this, okay, like this you will do. If there is a corticospinal tract weakness, there will be a flexion and adduction of the thumb. There will be a flexion and adduction of the thumb. Okay, if I give a flicker contraction to the middle finger, there will be a flexion and adduction of the thumb. This is Hoffman's sign. The Wartenberg sign is I'll prone like this and I'll hold the wrist like this. Yes, this is. So if there is a corticospinal tract weakness, the thumb will become adduct and flex. This is Wartenberg sign. This is a pathological signs. Especially if these signs are unilateral, then that has a more significance, the Wartenberg sign and Hoffman's sign. Okay, next. So next we will go to the deep tendon reflexes. Yeah. Now we will go to the deep tendon reflexes. Already we are told how to grade the reflexes. Okay, in the theory part, the reflexes are graded as 0 is absent, 1 is a normal ankle jerk, 2 is a normal brisk reflex which is a knee jerk, 3 is exaggerated, 4 is clonus. The important clinically relevant deep tendon reflexes are biceps, triceps, brachioradialis, finger flexion, knee joint, ankle joint. Okay, I will elicit the reflexes along with the root values I will tell. Okay, just will go to elicit. Now biceps to elicit, this is the ideal position what he has kept. Okay, he has to keep the hand like this, then we have to put a finger, thumb or the index finger, then hit like this. Okay, either ढीला छोड़िए, कुछ नहीं होता. The root value of biceps is C5, C6. For the triceps, take the hand like that. Okay, just above the olecranon process, you hit it. ढीला छोड़िए, ढीला छोड़िए, कुछ नहीं होता. डाउन साइड से पकड़िए, like that. Yeah. If you don't get the reflex, you can use the maneuvers, especially for lower limb reflexes. This is a generic maneuver. For upper limb reflexes, ask him to clench the teeth. We can do that. The root value of triceps is C7, C8. Brachioradialis reflex is just above the styloid process. You will hit it. Yeah, you can see the reflex contracting. Even biceps is contracting. The root value of biceps is same thing, C5, C6. Brachioradialis is also C5, C6. थोड़ा उससे जाइए. Finger flexion is elicited by putting a finger like this and hitting like this. So there will be a flexion of the fingers, It may not be elicited normally, finger flexion test. Okay. So in the upper limb, I want to tell two things: inversion of the biceps reflex, inversion of the brachioradialis, inversion of the triceps reflex. If there is a lesion at C5, C6 level, you won't get biceps reflex, that will be absent. Instead of that, there may be a extension at the elbow joint, and with absent biceps reflex, you may get a finger flexion present. Okay, this is known as perversion reflex or inversion reflex. Same brachioradialis, C5, 6 is affected, you may get absent brachioradialis, but there can be a finger flexion test can be there present. Inversion of the brachioradialis is a perversion reflex. Inversion of the triceps means triceps will be absent, C7, C8. C5, C6 is biceps, C6, C7 is triceps, C6, C7. C8, T1 is finger flexion. Biceps is C5, C6. C6, C7 is triceps. C8, T1 is finger flexion. So if there is a C6, C7 affection of the triceps, at sometimes triceps won't be present, but there will be a flexion due to the transmission of the impulse. That is the reason for the inversion of the triceps reflex. Now we will elicit knee jerk. Just I will elevate the thigh part. Then thoda aisa karo. Okay. Then you have to do like this. So knee has to be flexed like this. This is a patella, tibial tuberosity. In between that, you give a jerk. See, you got a reflex. ढीला छोड़िए, कुछ नहीं करते. Okay. ये टाइट करिए ऐसा. Okay, this is the way to elicit knee reflex. Contraction of the quadriceps you have to see. Root value is L2, L3, L4. The method to elicit ankle jerk is flexion at the knee joint. 90 degree you have to flex at the dorsiflexion of the foot, and then you have to give a jerk like this. Yeah, you got the reflex. See, this is the ankle reflex. You can make out the muscle contraction nicely. Okay, see here again it's coming. See, root value is L5S1. This is L2, L3, L4. Knee jerk you can also elicit by the patient dangling down the foot or even patient crossing over the foot. We already elicited the sitting once, now with the other. So this is how we elicit the deep tendon reflexes. So in a upper motor neuron lesion, deep tendon reflexes will be exaggerated, superficial reflexes will be absent, pathological reflexes will be present. So abdominal and cremasteric will be absent in UMN lesions. Both have same significance, cremasteric and abdominal. In UMN will be absent. Pathological reflex like Babinski will be extensor in a UMN lesion, and DTR will be exaggerated in a UMN lesion. DTR will be absent in a LMN lesion. Okay. So what all we discussed in motor system examination? The nutrition, tone, power, coordination and reflexes. Okay. So next class we will discuss involuntary movements, sensory system examination, gait. So now we have examined the motor system examination under nutrition, tone, power, coordination. Okay. The next thing is the reflexes. Okay. In the reflexes, so we will examine the superficial reflexes and deep tendon reflexes. Okay. So before examining the reflexes, I just want to tell the grades of reflexes. Okay. Grade 0 is absent, grade 1 is present. Grade 1 is like getting a normal ankle reflex, that is +1. Grade 2 is a normal knee reflex. A normal knee reflex is a brisk, that is +2. Grade 3 +3 is exaggerated reflexes, and then grade 4 is clonus. So I repeat, grade 0 is absent reflex, grade 1 is like getting a normal ankle reflex +1, grade 2 is like getting a normal knee jerk which is a brisk, grade 3 is exaggerated, and grade 4 is clonus. So after examining the reflexes, how you will record the reflexes in your case sheet, students? I will show a method given in Dijon. This is the method, right side and left side. So triceps, biceps, brachioradialis, you can record if it is 2 plus 2 plus like that, patellar, ankle, so here it is patellar, Achilles, that is ankle reflex, then plantar, with a flexor you can show an arrow diagram like this, down like this. If it is extensor you can show it up. Okay. So triceps, this is tricep, this is biceps, brachioradialis, patellar, Achilles and a plantar reflex. Okay. Now we will go with the examination of the reflexes. Dear students, last class we discussed about the motor system examination. In that the nutrition, tone, the power, the coordination and reflexes we discussed. I want to tell you some points about yesterday's class which are left out. Okay. One is how to distinguish organic hemiplegia from a functional hemiplegia. There is an important sign known as a Hoover sign which will distinguish an organic hemiplegia from a functional hemiplegia. What is Hoover sign? I will explain now. Suppose in a normal person, if you put your hand under the foot, ask him to lift the normal leg, or even in a hemiplegic person, if you tell him to lift the hemiplegic leg, what happens? Let us see. Yeah, so now I am feeling a pressure. Okay, pressure. This is associated movement. Okay, so in a normal person as well as in a hemiplegic person, this normal downward pressure can be felt. This is a normal associated movement. Whereas if the person is malingering or if he is a functional hemiplegia, at that time when I tell him to lift the hemiplegic leg, this normal associated downward pressure, he won't be able to feel it. This is a Hoover sign. Okay, right. Next, some of the points which I want to tell about the superficial reflexes is, one is anal reflex. In anal reflex, the perianal area will be scratched, and with a gloved finger, the anal sphincter finger will be inserted, and you can feel the contraction of the anal sphincter. The root values are S2, S3, S4 for an anal reflex. And some points about Babinski's. Suppose if you don't get a Babinski extensor, or you expect Babinski to be extensor in UMN, and if you are not able to get it, then you have to do some maneuvers. Those maneuvers are, okay, open arm maneuver. Open arm maneuver is done by, okay, from above top to down, you will press along the shin of the tibia. This is open arm maneuver. Or a Gordon sign. Okay, you will squeeze the muscle, the soleus and gastrocnemius, you will squeeze it. Or Chaddock sign. Chaddock sign is with a knee hammer, you will hit over the just below the lateral malleolus. Okay, lateral malleolus. These are some of the maneuvers which you do in Babinski sign. Then which are the conditions? Babinski can be extensor even though corticospinal tract is not involved. So which are the conditions? So child less than 1 year of age group, narcosis, sedation, coma, alcohol intoxication, post-ictal state, okay, and in the China-Stokes breathing in the apneistic phase, metabolic conditions like hypoglycemia, Babinski can be extensor even if corticospinal tract is not involved. Okay. Now next, in the deep tendon reflex, one thing which I want to demonstrate is whenever there is a clonus, how to demonstrate clonus in the patient. So clonus is mainly demonstrated at two sides. One is an ankle clonus and a knee patellar clonus. So I'll demonstrate how to do ankle clonus and patellar clonus. Okay. So dear students, the patellar clonus is done by holding the patella bone and then giving a sudden jerk, and that jerk you have to hold it there only to keep the stretch constantly. So you have to do like this and you have to hold it like this. If there is a clonus, you will get a movement like this. Okay, anything more than 6 is abnormal. Sometimes in ill sustained clonus you may get less than 6 contraction. So hold the patella here, give a jerk, and if it is there, it will come like this, patellar clonus. Okay, then ankle clonus. Ankle clonus is elicited by, see, this is a wrong method. You should not hold here. This is a wrong method of eliciting the ankle clonus. You have to hold here, flex at the knee joint, then suddenly you have to dorsiflex. Suddenly you have to dorsiflex. Okay, so suddenly you have to dorsiflex. If there is an ankle clonus, it will be a jerk like this. Okay, this is an ankle clonus. Then there are some conditions in which deep tendon reflexes will be absent, like spinal shock, low motor neuron lesions, anterior cell, root, peripheral neuropathy, shock, coma, narcosis, root disorders. There will be DTR will be absent. Then other reflexes which I didn't tell yesterday were primitive reflexes. Okay, the primitive reflexes which are examined are, okay, one is grasp reflex. So you put the two fingers over the palmar aspect of the hand, so patient will grasp your fingers. That is a grasp reflex. Next is globular tap. Globular tap is done by, so you have to come behind the patient, okay, and you have to tap on the glabella. See, after 2 times he is not closing the eyes. This is a normal phenomena. See, after 2 or 3 times he is not closing the eyes. But if there is a primitive reflex is there, then eyes will keep on blinking even after 3 or 4 times. That is a globular tap. Next primitive reflex is palmomental reflex. So palmomentalis reflex, you just scratch on the palm on the thenar aspect, there will be a contraction of the mentalis muscle, especially you get in Alzheimer's disease, old dementias and other conditions. Okay, right. So next is snout reflex and sucking reflex. So you just touch the angle of the mouth, okay, the mouth will open, that is a sucking reflex. The snout reflex is if you give just a percussion note on the lower lip, there will be a puckering, of the lips, that is a snout reflex. These are the primitive reflexes which are not normally seen in a normal person. Okay, these are primitive reflexes. Students, some little about the anatomical parts I want to tell about cerebellum, which I discussed last class. Okay, there are 4 nuclei of the cerebellum: dentate nuclei, vestigial, globosus, emboliform. And there are 3 peduncle: superior cerebellar peduncle, middle cerebellar peduncle, inferior cerebellar peduncle. The superior cerebellar peduncle carries the anterior spinocerebellar tract. The middle cerebellar peduncle will carry pontocerebellar fibers. The inferior cerebellar peduncle will carry posterior spinocerebellar fibers. So these are the points which are left out about the anatomy of the cerebellum yesterday. Okay, so till now we have discussed till the coordination and reflexes. Today we will discuss about the involuntary movements. Okay, right.